Good morning, good afternoon, good evening. Welcome, everybody. Thank you so much to those who are joining us live, and welcome to everyone who's listening in afterwards. I would like to warmly welcome our guest today, who I'm shortly going to be introducing. Our webinar today is entitled The Role of Community Pharmacists in Logistics of COVID-19 Booster Vaccination, the Opportunities and Supply Chain Challenges in a Post-Pandemic Scenario. For all of us, it's very important and a new area for many of us in pharmacy. Colleagues around the world, community pharmacies play an increasingly consolidated role in vaccination. During the pandemic, pharmacies' accessibility made them a convenient place for vaccination against COVID-19 in several countries. In addition, increasing vaccination coverage and helping achieve herd immunity is a huge imperative. As the world slowly begins to emerge from the pandemic, this event will discuss the role of community pharmacies in the COVID-19 booster vaccination and their challenge in vaccine supply logistics and cold storage solutions, particularly in a post-pandemic scenario. Key interventions by community pharmacists in vaccine supply logistics linked to COVID-19 from different parts of the world will be presented. And our speakers today will explore these in further detail during the webinar. But first, let me introduce myself. I'm Catherine Duggan, the Chief Executive Officer of the International Pharmaceutical Federation, FIP. It's an honour and a privilege to be moderating this event with you today. Thank you so much for attending, and thanks to our panellists for joining us today. As you can see on this slide, we have some announcements to make. Please note this event will be recorded and live streamed on FIP YouTube and will be available on www.fip.org. To all of those listening, please feel free to send your questions through the Q&A box. I'll do my best to manage all those questions during the panel discussion and that we have time, but we will also ensure the panelists can answer them and the team will field questions in the chat box too. You are welcome to provide feedback to us on webinars@fip.org. I'd like to take this opportunity to promote the benefits of membership with FIP, including our events and webinars. FIP is the global body representing over 4 million pharmacists and pharmaceutical scientists. If you are a pharmacist or a pharmaceutical scientist and you'd like to become a member, please register on our website at www.fip.org. Wonderful. So without further ado, I would like to make note of our panelists today. We have a panel of fabulous speakers, and I want to sincerely thank each of them for taking the time to prepare the presentations and to join us today. We're really lucky to have you. We know how busy everybody's schedules are. We have Dr. Vibhu Padwal, Associate Professor of Clinical Pharmacy at the University of Birmingham in the UK. We have Dr. Ronald Pierre-Vincenzi, USP Chief Executive Officer from the USA, and Dr. Maya Loganathan Fani, Senior Lecturer and Pharmacist at the University Technological Mara, Malaysia. A global audience, a global panel helping us today with our global perspectives. So today, I wanted to just walk you through what to expect from the programme. We will firstly have a presentation from Vibhu on the role of community pharmacists and their challenges in COVID-19 booster vaccination in a post-pandemic scenario. Then Ron will follow, and he'll provide a presentation entitled From Manufacturers to the Public, the Importance of Community Pharmacies in Successful COVID-19 Vaccine Distribution. And then Marla will present how to establish cold chain management of COVID-19 vaccines in community pharmacies, particularly in warm climates. You'll have the opportunity to ask questions. Lastly, I'll make some reflections on vaccine logistics and gauge some of your needs and wants and priorities ahead of the panelists making some closing remarks. It's a full programme, and I'm delighted that we have you all on board. So there's a number of learning objectives for our webinar today. Firstly, to understand the supply chain and distribution process of COVID-19 vaccines from manufacture to hospitals, community pharmacies and the public. Secondly, to explore the role of community pharmacies in vaccine supply and logistics for COVID-19. Thirdly, to discuss the challenges of COVID-19 booster vaccination supply logistics and cold storage solutions in community pharmacies, particularly in a post-pandemic scenario. And fourthly, to explore supply models that involve community pharmacies contributing to population vaccination coverage in a post-pandemic scenario. All of these are pertinent to the world we're living in today. Without further ado, I'd like to introduce you then to our first speaker today. Dr. Vibhu Padwal is an Associate Professor of Clinical Pharmacy at the University of Birmingham. He's currently the Chair of the Research Committee of the European Society of Clinical Pharmacy and Associate Editor for the International Journal of Clinical Pharmacy. Vibhu has a special interest in public health aspects of pharmacy practice. He has delivered externally funded projects and published extensively around health disparity and access to healthcare, with a particular focus on vulnerable populations, issues very close to the heart of FIP. During the COVID-19 pandemic, Vibhu has been leading research work around the impact of the pandemic on patient access to pharmacy and health services, again, hugely impactful for FIP. And since the rollout of COVID-19 vaccination, he has researched pharmacist and pharmacy staff involvement in the vaccination process. It's great to have you here today with us, Vibhu. I'll hand over to you for your presentation. Welcome.
Thank you, Catherine, and thank you to everyone from everywhere in the world. It's really exciting to see many of colleagues joining from every corner. And without any delay, I would like to start my presentation. I'll be focusing on the role of community pharmacists and particularly the opportunities and challenges leading to COVID-19 booster vaccination programs. Some of the challenges I'm going to discuss, unfortunately, were relevant during the initial phases of the pandemic, and we are still facing those challenges. But we also have some progress, which I'm going to highlight today. Next slide. So during the initial phase of the pandemic, our study shown that pharmacists showed resilience. They showed opportunities to innovate their roles during the initial phase of the pandemic by involvement, especially in the community, through provision of education services, routine clinical services, and many of the clinical care that were diverted from other areas in primary care. They also were directly involved in the clinical care of COVID-19 patients in hospitals, other sectors, facilitation of clinical trials, as well as provision, appraisal, and sourcing of evidence to other healthcare professionals. When we undertook the research, they were also, they expressed readiness to be involved in the vaccination process once vaccines were developed and approved. And now we have that situation. We're into the booster phase. So this was the study we've done across 16 European countries in the EU. We did this research through the European Society of Clinical Pharmacy Forum. Next slide, Ines, please. And what we've seen from the previous research, not just related to COVID-19, but this, for example, a systematic review published in 2016, has shown that pharmacist-led vaccination programs are widely accepted by patients, and quantitative studies have also shown that they help improve the access and rate of vaccination in the population. However, we know, and there has been suggestion, that political and organizational barriers often prevent pharmacist participation in vaccination programs. Next slide, please. So looking into the policy barriers, so we recently undertook a review of current practices and policies in regards to pharmacist involvement in COVID-19 vaccination in Europe. We reviewed legal framework, policy papers, services specifications, and grey reports from 13 different European countries. And these include Belgium, Croatia, Czech Republic, and many other, including the United Kingdom, where I'm currently based. Next slide, please. And of the 13 European countries that we reviewed the policies from, at that point, and this study we concluded in July 2021, and there have been some improvements since then. But at that time, of the 13 countries, only Switzerland, UK, and Ireland allowed direct administration of vaccines to patients by pharmacists, which means these were the countries who were at that point commissioning vaccination services through pharmacy. Of the countries that we didn't review, others like Poland and France also allow direct administration of vaccines. So in the vast majority of the countries that we included in our study, participation was often limited to vaccine logistics, supply, preparations prior to administration, and there are often quite a few barriers. I'm sure my colleagues later on are going to be explaining, and as well as patient education and counseling. But this, from our experience and from the studies we've subsequently conducted, that these rules were unfortunately not enough to make sure that we can vaccinate as many relevant eligible populations in the shortest possible frame of time, which is one of the pressing demand of the pandemic. Next slide, please. So since the booster vaccinations have been rolled out, lately we have Italy, of those countries that we reviewed, allow direct administration of vaccines to patients. However, there are some logistic barriers or requirements which the pharmacists have to fulfill, including having a reception area, an administration area, and a monitoring area, which can be a bit challenging in the context of community pharmacy. Policies since the booster vaccination program have been rolled out are beginning to evolve in favor of pharmacist-led vaccinations in countries such as Belgium and Netherlands. But then there are many other countries which are still in a similar situation where there have been calls to change the policies, but there are other political, organizational, and legal as well as educational barriers to enforcing the changes to allow pharmacists to participate. Next slide, please. So let's look at one example where pharmacists have got limited roles. So unfortunately, Dutch pharmacists now beginning to, the policies beginning to emerge there. But what do they say in terms of the legal roles? The administration of vaccination is a reserved act as per the Dutch law, which means under this law, only the doctors, advanced nurses, and physician assistants are considered independently competent to administer vaccine by injection. Now, they, this, if we further into these policies, often the reference made against allowing pharmacists or pharmacy member of pharmacy staff to be involved in vaccination often is referred to the cases of anaphylaxis. If we look into the next slide, anaphylaxis due to COVID-19 vaccine. Now, this is a recent sort of data from the Europe as well as the US. And the mean anaphylaxis rate from COVID-19 vaccine, if we look at the over about 1 million cases, there's only 10 cases per million cases of COVID-19 vaccines. How does this compare to the other vaccines being delivered in the community? The ranks 5th in the anaphylaxis rate, which means other vaccines that we consider safer, which public have got also more experience, better perceptions, such as MMR, HPV. The rate is quite favorable, and they are within the range of anaphylaxis rate for reported across several other common vaccines, which means that it is time that we, based on the evidence that we've got from over a year, from the initial phases as well as the booster vaccinations, that it is safer to administer in the community, especially when we have measures to treat and intervene any signs of anaphylaxis after COVID-19 vaccines, which the incidents are very, very low anyway, as we can see in the data. Next slide, please. So let's take an example of UK. So what have pharmacists been doing? So they have been in the forefront of vaccination drives during the initial phases, continuing through the booster. They commenced vaccinating COVID-19 vaccines in January 2021, and they can have a direct contract with the NHS England, or they can also liaise with the other primary care organizations to offer the service, which can be done in a pharmacy site, or they can also use other neighboring premises which are suitable to offer vaccinations. And they get remunerated approximately between 12 to 20 pounds per vaccination through the NHS England. And the good news is the technicians can also vaccinate under supervision as well, which means the whole of the pharmacy team, pharmacy staff can get involved, making sure that the pressing need to vaccinate the last section of the community in the shortest possible frame of time can be made real through the opportunities that are available to pharmacy staff. Next slide, please. So one example of a study about patient experiences from COVID-19 vaccination through pharmacy. So studies reflect high satisfaction. So these are the studies particularly focused on COVID-19. The previous systematic review I described earlier related to pre-COVID era. Here, this was a study conducted in France, and patient satisfaction was excellent with a rating of 4.9 out of 5. And about 60% of those who received a pharmacist administered COVID-19 vaccine had previously received other vaccinations, influenza, for example, most often in the same pharmacy, which means the administration of COVID-19 vaccine also enables building the trust to offer future immunization programs, other services through pharmacy. So there's not just that opportunity, which makes their services relevant to public health. And almost all of the respondents consider the vaccination more accessible when it's available in a pharmacy, because often pharmacies are located nearby where patients live, and there's often no need for appointment for COVID-19 vaccination through pharmacy. You can have an appointment, but many also offer walk-in services. Next slide, please. So opportunities through booster vaccination programs through pharmacy. Firstly, mitigating inequality in access. So many of the centers, vaccination centers we know, are operated through GP services, other clinics and hospitals, and they may not always be accessible to patients. And for example, in England, anybody who does not have an NHS number, a GP registration, even homeless patients, I have particular interest in this population in my research, and it's illegal to deny patients a vaccine on any of these bases. So anybody can walk into a service. Opportunistic interventions, as I mentioned earlier, other vaccinations, other services, public health, social prescribing, healthy living pharmacy initiatives can also be offered when patients walk into pharmacy to obtain the vaccinations, as well as there are opportunities to build the trust and counsel patients on a wide range of services relevant to them. Increase patient choices, as well as maximizing pharmacy and support staff role in public health and patient care. As we've seen, some of the countries often also require premises to be meeting the criteria of the regulators, in which case this pandemic also brings in opportunities for pharmacies to upgrade their premises. Next slide, please. So these are an example of how accessible pharmacies can be. So in the US, for example, 90% of Americans live within 2 miles of a community pharmacy. Very similar percentage of British population live within a 20 minutes walk to pharmacy. And as of April 22 in US, where pharmacists have been at the forefront of administering COVID-19 vaccine to a wide sector of population, over 241 million doses have been administered and through the retail pharmacies across the US, and this is growing. Next slide, please. So further barriers and opportunities. Now, having pharmacy premise available, as we know, isn't the solution to all the problems, but because community pharmacies have got that relationship, trust with the patients in the community, the pharmacy staff are the right personnel to combat any misinformation, any sort of hesitancy from patients regarding getting vaccinated, and also the opportunity to offer post-vaccination counseling, because if you walk into certain clinics and hospitals that you have never been to, so if there are any adverse events, side effects, or any sort of a patient concerns, it's many patients don't know how to get to that clinic again, or who to seek information about those adverse events. Now, because the pharmacists in the community would have been known by the patients, will have been used for other services, people will have that opportunity and relationship to go back again there to ask for any post-vaccination counseling and queries. And also asking patients to return for boosters if they haven't had a booster yet. Next slide, please. So we talked about how accessible pharmacies are in terms of delivering COVID-19 vaccinations and the boosters. Now, the studies recently, however, show that having pharmacies available to offer vaccination services isn't enough. This is a study, recent study conducted in the US. In the US, we have a distribution of vaccines as per the social vulnerability index. And as we saw in the previous slides, that about 90% of the population have got access to a pharmacy service in the US within 2 miles of radius, and often they're distributed better, as the case in the UK, in areas where there's higher social deprivation. So the most vulnerable counties by socioeconomic status and household composition in the US have higher vaccine site density. So this involves community pharmacy offering the services or other sites where patient can get the vaccines from. However, what the data is showing us is having the higher vaccination site density is a good thing, because population who live in a higher vaccine site density have got high rate of vaccination, but the differences isn't actually covered by how much the difference there is in terms of the vaccination rates in the community. So which means that in the socioeconomically deprived area, the rate of vaccinations are comparatively lower when we adjust for the differences in the vaccine site densities. Therefore, current measures where we try to maximize the equity in access to vaccinations by offering more sites or making, let's say, pharmacies becoming available to offer vaccinations isn't enough, because we need to deal with other access and structural barriers that prevent people from vaccination. So next slide, please. So what do we need to do further then in terms of promoting booster campaigns? As we saw, policy is the biggest barrier. So stakeholder consensus we need to have to allow policy changes. We need to share good practices and evidence where vaccinations are happening through the community in countries which have shown the way. For example, the Switzerland, Ireland, UK, and the US. There are also barriers here, but we can share any good practices and outcomes. And as we saw, having pharmacies available to offer vaccination isn't the only solution, because unless we deal with the structural barriers, racism in healthcare, discrimination, patient reluctance to use health services, their reluctance to get vaccinated, misinformation, then we can't ensure equity in access and make sure that the maximum populations are vaccinated in the shortest possible frame of time. And therefore, pharmacies, again, are at the heart of the community to offer patient education and counseling to address some of these barriers. We need to offer good remuneration models, because if we're taking time away from dispensing and other routine services that bring income to pharmacies, then we need to address those. And there's no evidence that administering vaccines in community pharmacy premises pose increased safety risk or make vaccine ineffective. And I'm sure the colleagues later on will describe how reassuring the vaccine services, the storage, transportation, logistic, and pharmacies are. So therefore, there's a good enough evidence from research, practice, and policies to make sure that other countries also allow the same. And we have experience of pharmacists prescribing, not just in vaccines, but also in other disease areas, which have been successfully tried and implemented elsewhere. And this can be a learning to improve the coverage and services being offered through community pharmacies. Next slide, please. So the key factors on implementation. So this is one of the consensus study with many different stakeholders published last year. So the key factors that drive implementation, of course, the policies remain the first thing from the policymakers' legal perspective, but staff training on correct vaccination procedure and basic life support, as well as having a good definition and clear roles, processes, and responsibilities in the team, and having a space room available for offering vaccination, as well as having a good pharmacy workforce is essential in making sure that more and more community pharmacies can offer COVID-19 vaccination services. Next slide, please. So thank you everyone for listening. I would like to acknowledge my society as well as FIP for offering the opportunity, and all my co-authors and experts that we have in the team, and the ESCP, which have allowed us the forum to undertake some of the policy research, and the International Journal of Clinical Pharmacy, which is the partner to our ESCP society. Right, and next slide, and some of the related COVID-19 work that we've been involved in, and happy to share the work with colleagues. And, thank you to FIP again. Thank you, Catherine. And I'm happy to answer any questions in the chat box or towards the end of the presentation, my colleagues' presentations.
Thank you so much, Vibhu. I think many of the issues you raised today are very, very close to FIP's heart. Our vision is about ensuring everyone has access to safe, affordable and effective medicines, and vaccines is part of that. And understanding the inequities and inequalities and access issues are really, really important for us to unlock how we can be part of the solution. Thank you so much for saying you'd share these references. I think having this body of work is going to be super helpful for not only today's event, but further work as well. I think there are a couple of questions in the Q&A box, Vibhu. Happy for you to respond to them, and then we'll take the emerging issues in the panel discussion a little bit later.
Yeah. So I think, yeah. So the first question on what are the bases on which countries depend to allow pharmacists to administer vaccines. I think some of these are relevant to historical policies where pharmacists have been actually offering influenza vaccines as well as other vaccines through the community. So that experience actually allows pharmacists to continue with the COVID-19 vaccines, particularly the pressing need to vaccinate the population as in the short frame of time, as well as the policy barriers not having been there, such as in Dutch case, as we saw, that there's clearly defined in the law that only doctors, their assistants and nurses are allowed to vaccinate, but pharmacists are not. So therefore, these policies do remain a barrier. So what policy changes allowed pharmacists to administer vaccines? Again, I would probably answer in the same way, where certain rules are defined within the law and pharmacists cannot uptake that role, that becomes a barrier. So we need to first change the policies to influence practice.
Yeah, very good.
Yeah.
If you want to put some specifics, write them into the Q&A box, Vibhu. I think people would really highly value that, and we'll save all of that for the after the event. Thanks so much. See you in a short while.
Thank you.
Wonderful to have you. So, colleagues, without further ado now, I'm going to introduce our next speaker, Dr. Ronald T. Piervincenzi. Ron began his tenure as Chief Executive Officer of USP in February 2014. He provides strategic leadership to the USP's global staff of over 1,300 across regions including North America, Latin America, Southeast Asia, the Middle East and Africa, Europe, and global public health field offices across 9 countries. Under his leadership, USP has modernized its operations and launched innovative new science, including in the areas of digital medicine, cutting-edge manufacturing technologies, and advanced biologics. Ron brings more than 20 years of industry experience across pharmaceutical sciences, research and business strategies. And before joining USP, he served as Vice President of Development Scientists with Biogen and was a partner and leader in McKinsey and Company's global pharmaceutical and medical products practice for over 12 years. Ron earned his MS and his PhD from Duke University in biomedical engineering with research focused on protein engineering. He's the proud co-founder and chairman of the board for Mentor Newark. Thanks so much, Ron. I know how busy you are, and everybody else will see from your eminent CV just how much your time must be pressed, but it's so great to have you here today. Over to you, Ron.
Thank you, Catherine, dearly, and always my pleasure to partner with FIP, and looking forward to Sevilla in the fall. I have a very brief presentation to make sure we have time for our Q&A at the dialogue. And I'll just share with you 2 slides about where USP comes from sort of the basis of our experience and knowledge that we bring to bear, and then a little bit about how the work we did that was surrounding the COVID-19, especially around vaccination, but not only, and then specifically the work that was most related to community pharmacies and the critical role they played. So next slide, please, or perhaps it's 2 forward. From context, of course, as we know, we've often referred to the flu pandemic of the early 1900s, and given that USP has now celebrated our 200th anniversary a couple of years ago, actually during the pandemic, unfortunately, there's a sense we really can learn from history. And even though we have vastly different and new tools today, some of the challenges from even far back are still with us. Next 2 slides, please. This is just a footprint, and I mentioned this about USP's footprint in the world that Catherine did in the presentation to kind of give you a sense of what it really takes, as we now realize in a global pandemic and a global medicine supply. There is no way to do this without collaboration and work around the world. And most of USP's offices and staff around the world you see in that purple column, about engagement. And I think that's the key here, and why organizations like FIP bringing together the global community are so important. Next slide, please. And underneath this is what, of course, most in industry and in pharmacy know USP for, our standards, the foundation for our work. You see on the left-hand side that sort of the comprehensiveness. What was so unique to us about the pandemic is that it brought forward nearly all, not literally all, but nearly all the different areas where we have standards and expertise that was brought to bear. And I'll give you a couple examples of that in the next couple of slides. Next slide, please. One more. So when we take a look at the broader view, when the pandemic was first, actually even before it was first declared, we do have USP colleagues in Shanghai as well, and in terms of both protecting our own staff and also starting to learn and realize what this was looking like. So even before the declaration of pandemic, we had personal and close experience to recognize what was coming, and we started already asking the question: what will healthcare workers need, manufacturers themselves, and not only vaccines, but also for direct therapies and even some of the related products that were ending up and moving into potentially into shortage. And then, of course, regulators around the world to make sure that there's a smooth path between and getting the right and the safe and the quality medicines and other critical materials in the hands. Next slide. And so as we kind of dug into this, the first thing was really discussions, and very quickly, like where are the gaps? Where are the challenges? And we worked with organizations, including FIP, World Health Organization, and we started asking a combination of the needs, and then map that to the scientific expertise, not just by USP, but also our what we call our convention members, which includes FIP. And we asked about standards, about everything from compounding through packaging, labeling, stability, storage, and also the standards related to the manufacturing of the treatments, and then a little bit later on in the pandemic, of course, vaccines. Next slide. So one specific area, and I thought the focus for most of my just maybe the last couple of slides here, is to focus on what we call the vaccine handling toolkit. This was a set of work that began, I think, quite humbly with a call from the US CDC and asking a set of very simple questions that they started to receive or that they were going to be emergency authorizations for the first couple of vaccines. And there were questions about the final delivery. And of course, many vaccines have been delivered before, but around the world and including in the US, there was a very different approach taken, much broader involvement of community pharmacies critically was one of the best decisions made in the administration of vaccines. But at the same time, multiple vaccines, brand new at the time, requiring different handling, different dosing, multiple shots, required a whole lot of responsibility at the point of care by the pharmacists themselves. And so what we started to create was something new, which was not quite as standard, but we just called it a toolkit, because it was really just a set of practical instructions for how to be able to receive that box at the loading deck, different temperatures, of course, for the different vaccines. And the first 3 that were approved specifically in the US all had 3 different storage conditions and also 3 different doses, dosing regimens, different types of syringes were required for all 3. And therefore, the toolkit was there to make a practical use for the final administration to prevent errors, but also to help optimize the number of shots, which was so critical, especially early, but even now in maximizing availability and managing costs. Next slide, please. And so here I want to talk that it started, again, the first version was for US only, or was focused on the US, I should say. And now subsequent versions have broadened to include many, many other vaccines, even many that are not approved in the US, to be used around the world. Again, covering the different types of vaccines, different doses. And of course, even now we have different doses for boosters, which can often be, or in many cases are actually required different tools, different syringes. And one of the things about, we wanted to make sure we empowered the practitioners with a set of not instructions that were required to be followed, but it would be helpful so that everybody could adapt. The previous conversation, you saw how conditions could be so different that we were unable to be able to say exactly what your situation would be, the volume of vaccinations, the place of vaccination, is it in one site or is it a mobile unit? And therefore the toolkit was really there to say, this is the basic foundation for how to be able to use each of the vaccines. Next slide, please. So after we issued the toolkit and it was in use for several months, we conducted a survey. So this was just late last year, so it's pretty fresh data. And we asked a series of questions, but they were all very practical. What was most difficult in administering the vaccines? And the goal of this, of course, was to learn, to see what the challenges were, but more importantly, was to then say, okay, so then for future vaccinations, whether through a public emergency like the pandemic or even normal vaccination efforts, what are the critical questions that a practitioner is asking? The pharmacist right at the front lines, what are they challenged by? And what we came up with in this series, and I broke it up into these three tiers because it seemed to fall into 3 categories. The first, the things most practical to the pharmacist at the front line: vaccine wastage, just making sure everyone knew how to administer it. And of course, the dosing issues with regards especially to different vaccines and different doses for first, second boosters. The second category had more to do with the ability to trust the vaccine. So the substandard and falsified vaccines, which unfortunately becomes a real challenge. Compliance with local regulation, which isn't just about the approval, but how to be administered and who is able and actually authorized to administer. And also compliance with international regulations for donated vaccines and other things like this. The third category, which we had fewer responses, was about the manufacturing and the delivery, which is not surprising given that this survey was conducted to the administering pharmacist. So the takeaway we had from looking at these questions is that what we called the last 50 meters, the administration right at the front end, is where most of the concern falls. And in fact, the vast majority of respondents were concerned about things like vaccine wastage because much was wasted in the process. And as the number of vaccinations starts to decrease, you actually can see the wastage actually increase. So a couple of things from this is we've continued to update the toolkit. In what we call the international toolkit, more and more vaccines are being added, changes to doses for boosters. So please, we would encourage anyone who has any questions about that to reach out to USP. My next slide can give you information. I may be able to pass that on. Next slide, please. And finally, I just want to say thank you. I moved quickly so we could have time for our Q&A, but I'll be in the chat box as well, in the chat box, and then Q&A questions for later. Thank you so much, Catherine.
No, thank you, Ron. I think there's a lot of overlap there with the issues that Vibu raised around equity and access, and so much practical advice. This will really help us think what we can learn for other logistics issues, as well as how would we better manage the next pandemic. No one wants to think about that, but we do need to have a gathering of resources. Super presentation. Thank you so much, Ron. If you'd like to just take a little look in the Q&A box and answer in writing, we'll bring those questions to the fore at the panel as well. And we'll see you in a short while, Ron. So that brings me to our third speaker today. A huge pleasure to welcome Dr. Mala Loganathan Farney, who completed her postgraduate training in public health pharmacy from Imperial College London in 2012. She's currently attached to the Faculty of Pharmacy in a position she's held for 15 years in Malaysia, in Mari. Mala had worked with the Ministry of Health Malaysia prior to joining academia, where she was instrumental in drafting the Traditional and Complementary Medicines Act. Mala has also worked for several years, combined at both private and public hospitals as part of a collaborative effort to provide clinical services. She has also been engaging with a continuum of community-based organisations in their efforts for outreach, from consultation to shared leadership of promoting COVID-19 vaccination and beyond. She has authored and published several key papers in leading journals in the field of prescribing for older people, antiretrovirals, the safety culture, and health-related services. Thanks so much, Mala, for joining us today. By no means your last, but by no means least, it's over to you. Thanks a million.
Thank you very much, Dr. Dugan. A very warm welcome, everyone. So good morning, good afternoon, good evening, wherever you are. Hope you're well. So firstly, I would like to express my thanks to FIP for inviting me, and also to Catherine and team for this wonderful opportunity, and also for bringing pharmacists of the world together. So first thing first, Malaysia and many of the neighboring countries, much like what Vibu has said, like the Dutch, we are not, so pharmacists are not vaccinating the public as yet. Okay, we've got training programs going on, and a lot of work is underway. So it's possible in the near future, but not as yet. So what I would like to highlight today is how we establish a secure cold chain management of the COVID-19 vaccines for end users. So I believe this applies also to community pharmacies, and more importantly, primary care. So for the moment, we are looking at GPs over here in Asia. So next slide, please. Okay, as we know, much of the challenges with cold chain lies with the mRNA vaccines, all right? So the Pfizer vaccines. So the other vaccines are pretty much okay with normal sort of just temperature controlled mechanisms. But with mRNA, because it is a lipid membrane based vaccine that's translated into antigen, so we have these additional layers of challenges. Next, please. From the perspective of manufacturers as well as the pharmaceutical industry, there are many bottlenecks, if you like. So there are issues with, for example, getting the raw materials, equipment shortages as well. And then we have got manufacturing process complexities, okay, which is where cold chain requirements fall. The other challenge would be to do with the capacity constraints. But as you can appreciate, all the other challenges are somewhat easier to address as compared to the cold chain logistics. So in the next few slides, I'm going to share with you why it is important not to break the cold chain sort of links. So if you look at the top box there, so The mRNA vaccines are produced in the factories, all right? And over there are not much issues to do with maintaining the temperature. Okay, so when we say temperature for cold chain, ultra cold chain is between -78 degrees to -20 degrees Celsius, all right? So much of the issues lie when they leave the production site. So when they leave, they are packed into dry ice containers, okay, which are then transported either by air or by land. And then at the port, once they've arrived, they get transported as well via land to the administration sites. Okay, so these are your end users, the public who would receive the vaccines. With the viral vector vaccines, so if you look at the lower box, the temperature at which they have to be maintained is between 2 to 8 degrees Celsius. So that is more manageable. So for that reason, we have much of the challenges lie with the mRNA vaccines, so i.e. the Pfizer vaccines. Next, please. Right, so in warmer climates, there's a need to replenish the dry ice. Okay, and there are issues with dry ice as well, which I will touch on a bit later. These containers are also equipped with GPS-enabled temperature monitoring devices, okay, to ensure that the distribution is within the required temperature range. And upon arrival, the vaccines are transported also into cold chain freezers. And because of the short duration that you have before the vaccines lose potency, so i.e. 5 minutes, so this poses an extra obstacle to managers and those handling these vaccines. These vaccines can be thawed in the refrigerator, so at 2 to 8 degrees, but they can be only kept up to 5 days. So that's about a very short time before they have to be discarded because they lose their potency. Each dose will also need to be diluted with normal saline before use. And once diluted, they are only stable for up to 6 hours. Pfizer has incorporated a QR code that is linked to the EUA website. It has a lot number and expiration date on the label for each vial. And this helps to record and ensure that documentation is not missed at every stage. The good news is Pfizer had submitted data to the FDA to update their storage requirements to more reasonable temperatures. So now ranging between -25 to -15, which are perhaps more manageable. Next, please. In this study, much of the deviations in the cold chain management was found in the transportation part of the cold chain logistics. So what happened is there's a lack of appropriate cold chain equipment such as cold chain boxes, cold chain trucks, and efficient refrigeration system. So as you can see, from storage side up until the end users, so much of the challenges lie in sort of in between these 2 points. So you've got ultra cold freezers at the manufacturing site and as well as the end user, so i.e. your hospital or your primary care centers, but not so much to reaching the patients, okay, which is where, as Ronald said, much of the wastage has been seen. So we call that the last mile, and I will touch about that a bit later. So as mentioned previously, the difficulties are associated with managing the last mile. So the last mile is the delivery from the site of the ultra cold equipment to the public, so the end users. So performance of the last mile delivery comes up against very significant technical and urban constraints. So getting vaccines from the factory to centralized platform and then distributing to decentralized unit is expensive, and it is also a complex procedure. So many hospitals and pharmacies do not have sufficient infrastructure to store vaccine doses. So as you can appreciate, this is even more severe in developing countries. So problematic because dry ice packs will only be able to be opened twice, and they will store vaccines for a maximum of 10 days. Next, please. Some of the challenges, so for example, in Malaysia, the last mile refers to very remote areas, rural areas, which are not accessible by road. So some of these areas have to be assessed by not land, but by rivers, actually. So mobile clinics in rural areas are set up to cater for people living there. So while the flying doctor services is provided by helicopters to indigenous people who live deep in the jungles and cannot be reached by any other means. So they've also tried to use unmanned aerial vehicle, so using devices like drones in order to drop some of the equipment. So we're not just referring to vaccines, but also the syringes and also all the equipments that are needed along for the process of vaccination to be successful. So the pharmaceutical groups are looking into using aerial drones to deliver vaccines to hard-to-reach remote areas. Portable vaccine carrier has helped to solve many of the problems in India. So, and in the past, trial and error was done with thermos flask and thermocol. So basically, these are your styrofoam boxes, which aren't very effective in keeping the temperature low. So technology startups have created battery-operated vaccine carriers and equipped them with alarm, and which can be remotely monitored. So new battery-powered boxes could last up to 8 hours now, and that is seen as a success. Next slide, please. So the travel time here takes 2 hours by river to get to rural areas of Borneo. There is no audio to this visual. So there was a time when vaccines were precious, and they were guarded by the security armed forces. And in addition, because of the hesitancy to vaccinate, talks had to be done, and we had nurses and medical professionals, including pharmacists, who were on outreach programs, and they did talk to these locals. Okay, many of them are indigenous to the areas. Knowledge transfer and talks for the locals to improve the vaccination uptake. And the other issue that we had was the unused reconstituted vaccine doses had to be returned back to the local district office or clinic because some areas did not have or had electrical supply cut off. So when electrical supply were not available, so the trip had to be made twice to deliver the vaccine back to its refrigeration system, and then to bring it back to the public the next day. All right. Similar to much of Asia, in Peru, for example, 30 ultra-cold freezers existed, but none outside the city of Lima. So this highlights problems of really outreach and really trying to get vaccine to be given to as many people as possible, including those in the remote areas. Specialized freezers will take about 4 to 6 weeks to produce, and the cost is somewhere between 10,000 to 25,000 USD. So the suggestion to top off containers with dry ice every 5 days to keep temperatures stable is not quite practical, because dry ice may be scarce in these areas, and also shipping dry ice sublimates and transforms into carbon dioxide gas, so that is costly and as well as it is dangerous. Next, please. So many companies have tried to innovate. Cold storage facilities of food chain were required by India's government to do a minor redesign of storage spaces to accommodate such need. So the advanced cold chain equipment, such as long-lasting passive cold boxes, medical refrigerators, and refrigerated trucks were used to facilitate effective storage and transportation system. Digital temperature sensors such as thermocouples, resistant temperature detectors, or thermistors could help to provide accurate data. The purpose-built units of pharmaceutical-grade units were also used instead of household or dormitory-style refrigerators or freezers. So what we're trying to say is food chain, cold storage facilities, innovations were made for them to be able to store these vaccines at the required temperature. In addition, digital temperature tags were useful. Vaccine manufacturers began to airlift vaccines in cold boxes with digital temperature tags to 4 major depots in 4 major states. They were then transported to specific facilities via airplanes or insulated vans, after which they were stored in temperature-controlled facilities. And these vaccines were held in ice-lined refrigerators in districts and then transported again using cold boxes. Simultaneously, the COVID Vaccine Intelligence Network is a cloud-based digitalized platform, so which helped to also monitor the temperatures of these 29,000 cold chain points in real time. Next, please. Okay, so all the data that I've presented were actually based on the scoping review that we had published in the Journal of Pharmaceutical Policy and Practice. So that was actually a review based on studies conducted in US. There were 6 of them. India, there were 2, Finland, Spain, Bangladesh, Netherlands, Switzerland, and Ethiopia, 1 each. So they were reported as reviews, policy or guidance documents, experimental studies, case reports, expert commentary, and from a phenomenological study and decision-making trial and evaluation laboratory trial. Okay, so what I would like to highlight that innovation was key. So vaccines that there were challenges with ultra cold chain. So vaccines were tested to see if they still maintain potency when they were used outside the cold chain, how long and to what extent that was actually possible. In addition, experiments were done. So refrigeration solution that used a commercially available refrigeration container was transformed from global cold food chain containers to meet the requirement for vaccine storage, and also an environmentally friendly solar photovoltaic powered thermoelectric based micro cold storage was also tested to see if that was suitable, and it was found that it was suitable for last mile vaccine delivery. There was no degradation to the vaccine. All right, so with that, I would like to acknowledge our collaborators who also published, who co-authored the scoping review. So University of Huddersfield, in particular, Professor Zahir Baba, Qasim University, Saudi Arabia, and as well as Malaysia. Thank you very much. If you have any questions, I will be happy to take them in the chat box or at the end.
Thank you so much, Molly. That's absolutely super, very comprehensive, and a lot of learning to be shared across other areas of practice where we're going to need this learning. There are a couple of questions in the Q&A box, but I'm going to get all of the panelists now, all of our speakers, to put their videos on, and we'll start the panel discussion, spend some time there. And I'll take the Q's and A's, the Q's first and then the A's, because I know that both Vibhu and Ron have answered a couple. Speaking of which, I think, Vibhu, you walked us through the questions that you had. Ron, did you answer the question around, does the pharmacy need to keep an AED if they provide vaccination?
Sorry, Catherine, could you repeat that question?
Were you the respondent? No, I think it was Vibhu again. Does the pharmacy need to keep an AED if they provide vaccination? I think that's, sorry, Ron, I misspoke. Vibhu, would you like to just walk us through that question or your answer? I think you're on mute, yeah.
So any facility providing the vaccinations should have provisions to manage anaphylaxis. And also, in addition to that, in the UK here, so the emergency departments have got special teams to deal with anaphylaxis related to COVID-19. So if there's an emergency call, anybody who's had a severe reaction to the vaccines, they have a specialist treatment team also in the emergency departments of the hospitals. Yes, so the answer is yes.
Fabulous. And I think that would be really handy to have in our guidance as well, so that we'd have the essential elements all thought through. So there are two questions for you, Marley. I just wonder whether I can walk you through those and you could give us some verbal answers before we move to the panel discussion. The first one is around, do we have studies indicating temperature variation during COVID-19 storage at facilities or during distribution? I think you did answer that, but would you just like to remind us of the answer?
Yes, actually, so specifically the study from US, Dadari et al. So they did a study and they looked at the different aspects of the cold chain, and they did look at the sort of degradation in the vaccine. So they found that, so it can actually be, it's just a matter of time. So your window, your time frame that you have is just much shorter. So once reconstituted, you have about 5 hours. So it's just a matter of keeping it in the right temperature, and for how long, that's really it.
That's very helpful. And again, as we learn more about these short life storage solutions, I think these will become increasingly valuable. The second question for you was, what was the rationale for developing a vaccine by Big Pharma, which requires such stringent storage conditions? I think we were all asking that question, weren't we?
Yeah, I think we are. We were wondering, weren't we? But I think we were really quite, at that point in time, it was so, there was a dire need, and we really needed it urgently. And I think mRNA is a important, and it has proven to be beneficial in that it was quick to develop. So mRNA technology in itself, it's quite good at churning these vaccines quite quickly, probably an advantage over the others. So that was probably the sort of rationale for coming up with that sort of vaccine.
Thanks so much, Marla. I think in future, we're going to have to learn how to balance that logistical issues together with speed of safe vaccines being produced. Lots of learning to be done. So, colleagues, I've got some questions I'm going to bring to the floor now, and I'm going to go round the speakers so we get the different perspectives from each of you. Or if you feel like the previous speaker has said what you would say, no worries at all. I think there's a really good question here about examples, building on what we've heard today, of how the COVID-19 vaccine distribution process works from manufacturer to hospitals to community pharmacies and the public, or taking some of those steps out. So I'm going to start with you, Vibhu, first of all. Any example?
Catherine, sorry, I had a signal disruption. Can you repeat the question?
Not a problem. Any examples of how COVID-19 vaccine distribution processes works, or actually where there were problems from the manufacturer to the hospital to community pharmacy and the public? Any examples of where we saw success versus problems? And the same question will come to Ron and to Marla as well.
Yeah, I mean, we have, since the vaccines were made initially, there was a big supply problem. And, at this stage, we haven't yet fully solved it, but, the situation is much better. And we've seen some good distribution practices in terms of vaccines and centers being distributed as per socioeconomic deprivation, as in the US. And because pharmacies here are predominantly more situated in areas where there's higher deprivation, so the vaccine distribution, from the equality perspective, has been balanced from that way. So what I think is, where there are less or no access issues, the services or the pharmacies that have been set up, we say it's the I'm struggling to remember the terminology, but more prevalence of, or the pharmacies being situated in an area where there's more need actually is helping driving the vaccination process in a faster way. So I would say that this positive distribution of pharmacies against the deprivation socioeconomic situation of a community is actually helping quite a lot. So I would say that's an example. That's a model that can be applied in countries where pharmacies have not been distributed so evenly. So that solves one problem. So the problem at the moment we have, if we look at the data where we have communities being less vaccinated than the others, is more about that structural barriers of people's relationship with the health services, their experiences with the health services, and their attitudes to vaccines in general. So these structural barriers are still a problem. So I would say that where we have the mechanisms to actually get the vaccines from the manufacturer to the end users, we have to have those structural barriers and public perceptions in favor of being vaccinated. So I think that's something we need to solve now.
Fabulous. I think this is a really nice way of thinking things through. So what was the benefit of having the pharmacy networks in certain places, and how can we, I suppose, mobilize or amplify that, and then looking at the problems we still have to face, because we always will do. Ron, do you have anything to add from your examples to those observations?
Yeah, thank you, Catherine. And it's an interesting question. It's framed in a way you don't typically hear. So I'll offer a couple things, and maybe it's the basics. From trust surveys it was actually many countries. I was thinking of one that was conducted by Edelman in the US. This is broad. This is not even limited to healthcare. The single most trusted profession in the survey were pharmacists. Number one, and I know you know that, Catherine, but this is wonderful. So probably the single best decision made in the vaccination campaign was to use that. And it was brilliant for two dimensions. One, of course, is you have reach. And the second, of course, the ability to do so. And the second, though, was to leverage that trust when it was really and sorely needed. And I think more than anything else, that was the critical piece. Now, there still are the challenges to reach, of course, to the pharmacists. But really speaking about strengths here rather than the gaps, that was super critical. Now, in every country and even in regions, there were different degrees of already delivery. But what we saw was pretty much an increase of the role of the community pharmacy and the pharmacist everywhere. And in some places, a dramatic increase that I don't think will slide back. And I hope it doesn't slide back. And then the second part is, given that in the future, it allows us to simplify some of those supply chains because it is clear where most of those vaccinations are going to come. And I think that is a potential advantage next time, as long as we don't backslide on the use of the community pharmacist and the building of trust and really, of course, the delivery. Thanks, Catherine.
Well, that's superb observations. And I think when we should start with what we have in the basket already, rather than always looking at the challenges. I think it's the best way, especially as we're 100 and something weeks into the pandemic now. People feel weary with all the challenges we faced. I really like that. And there's much to be done.
100 and something weeks in, Catherine, but when you think about it, it's still, even if the first vaccine were to arrive today, it would still be the fastest vaccine in history. Just think about that, right? We have to, I agree with you, Ron. I think to put it in perspective as a series of successful responses, as well as lots of lessons to be learned, would really change our mindsets right now and really help our frontline profession in the weariness, I think, that people are feeling, the fatigue. This is a really good approach, Ron, and one that we hope to have at FIP. The trust piece can't be underestimated. You're quite right. And we can use that to advocate and to influence policymakers in this remit. We'll definitely take that on board. Last but by no means least, Marla, do you have anything to add to those examples that we've just heard?
Not on those points, Catherine, but I would like to say something about the use of antihistamines. So there has been a question that I can see over here. So I think the use of antihistamine is, okay, I think the World Allergy Organization, I think the anaphylaxis committee doesn't quite recommend the use of antihistamines because it may mask the symptoms, so the initial symptoms. And then the second question on whether, okay, when we reach to many people, I think there's concerns when we reach out to those in the rural areas, how are we managing anaphylaxis and so on. So I think the usual protocol with any vaccination, when there is anaphylaxis, putting patients in reclining positions with their legs up, administering adrenaline, followed by normal saline if there's a BP drop, the sort of administering oxygen. I think all those protocols are in place, and good thing is these devices are, portable. So I think, there's not much issues with vaccination centers or primary care centers or even hospitals. But I think the question probably was more directed towards those rural areas and hard to reach places. So I think the good thing is we have injections, boluses, and these medical devices can be transported. So that's good news for us. But again, I'm not an expert. I thought I should just take that question. Thank you.
Good spot, Marla, really good spot. And I think that's really valuable. It feeds into the practical side of the questions that we're getting today, as well as some of the more, what I would call like policy or strategic questions we've had today. I think there's one more question. Who would like to take that? Most countries are making efforts to reach many people with COVID-19 vaccines. How is India and other countries in the low middle income countries prepared to manage anaphylaxis during outreach sessions? Anybody able to take that question? I think it flows quite well from your response, Marla, but Vibhu, do you want to take that?
Yeah. As Marla mentioned, some of the equipments as required by the protocol to deal with anaphylaxis, fortunately, are portable, and it's at the moment, compared to what we used to have a few decades back, are more accessible in the communities in the low and middle income countries as well. But it's a very important question because the challenges with vaccine hesitancy and misinformation is, some of the themes that we hear are very similar here and in low and middle income countries. And when people don't see that reassurance, as if something goes wrong, let's say, fortunately the incidence of which are quite low anyway, to deal and manage with any adverse events, when they don't see that being right in place. It can actually put people in off, even those who actually trust vaccines. So it's very important to make sure that we have the resources available in low resources setting to deal with any adverse events post-vaccination. So the answer to that is, I think when we think about vaccination rollout, when we think about procurement, when we think about donations, helping each other, we just not think about vaccines, but we also think about what other logistical requirements, including those in transportation, as Mala just mentioned earlier in detail, including the any management of adverse event post-vaccination, also need to be included in that thought process, so that that package of care comes with everything that we need.
That's a great answer, Vibhu. I think it builds on the implicit trust that patients and the public have in us. But if we start to become a little more explicit about all the steps that we have taken as a profession to ensure we've got safe supply, safe storage, and good management systems in place, I think that will increase trust. And I also think it's not just about the vaccines, is it? It's about all of the logistics and all of the infrastructure, as you rightly say. There's a lot more to it. But that would be a very good thing to explain to patients and the public as well. Like the whole sense that as a profession, we're on it. We understand all the mini steps as well as the big steps involved. I've got one more question now, which is around any examples. Coming to Ron's point, what are the opportunities as well as supply chain challenges in a post-pandemic scenario? What do you see as the big things now that we call ourselves post-pandemic? Of course, we're still in some form of the pandemic, but what do you see those opportunities and challenges? And I'll ask this of each of you, and then we'll move to a couple of reflections from me, and then I have a final question to come back to you all at the end of the session. So I'm going to start with Ron first.
Yeah, thank you, Catherine. And maybe this is a way to broaden this to, so how you don't want to do it. You don't want to create a separate supply chain and plan for each medicine, every vaccine, and we say, of course not, and yet it's kind of what's happening. So I look forward to perhaps vastly increasing availability of biologics overall through the world, and with the emergence slowly, but at least emergence of biosimilars, increasing access to these critical therapies that require some, perhaps not always as challenging, but some of the cold chain requirements and some of the complex dosing. In other words, there's a lot of medicine out there that we need to be able to get to people, not just the vaccines. And of course, they could benefit from almost the same pipe with some variations. So I mentioned that as, I guess, an opportunity, but maybe to come out of the pandemic and say, okay, now there are, for every individual vaccine, there are 100 additional biologic drugs for oncology, for you name it. That's what I would love to see happen. And then the benefit is, if you have that larger pipe for all those medicines, and now you have a surge of a vaccine or a specific treatment, it is only 1 out of 100. You're much more likely to be able to put it through versus opening and shutting these pipelines when you only have a pandemic. So that's my hope, that there's that becomes a momentum that makes it less challenging. And we've seen that in markets with that pipeline already. Thanks, Catherine.
Oh, Ron, that's so important. I really think that we have to think about this as a system change, and we see some shortages and supply issues as we've come out of the pandemic with so many things. Medicines are a fundamental risk to us all. All our countries have got different shortages, issues. So this is a really practical approach and feeds into my next set of questions very nicely. Any further reflections from Mala or Vibhu on that exact question?
Yeah, if I were to add, I would say the biggest challenge, and thus perhaps the ongoing challenge in the post-pandemic scenario, is the inequality. As we saw in the inequality in mortality, and clearly see, a very high mortality during the initial phase of the pandemic, especially pre-vaccination. So through the pandemic, even with the, when it was the mortality rates were very high, obvious to see. we couldn't, and when the vaccines came out, we couldn't deal with the inequality in access to vaccinations and also healthcare in general. So going forward, I think if we have not been able to deal with equity in vaccine access and the rate of vaccinations across communities, even during this, very sort of a tough pandemic, I think going forward, we have that challenge to still deal with. And unfortunately, I hope there's no, and we cross our fingers that we don't see another like this in our lifetime and in the future. But if there's any, I think we need to think about how we deal with structural barriers in making sure that people actually have, build the trust with the health services, health systems, and healthcare interventions that we've got, and people have confidence in science and, going back to the basics of public health about structural determinants of health, how we reach out to communities, to the communities that are socially deprived, to certain ethnicities and any other characteristics that makes vaccines less sort of utilized. And I think it's the role of our healthcare professionals, healthcare system, to actually make sure that we have very inclusive health systems and everyone has the same level of trust where possible in terms of the risks and benefits offered by the vaccine. So going forward, I think we still have that challenge to deal with. If we've not been able to deal with during this pandemic, I think it's going to remain there for the future.
Yeah, so on the one hand, lots of opportunities to make a system-wide approach more applicable to other products for shortages. On the other, we haven't quite addressed the hesitancy, the place of science and facts and evidence, as well as all of the equity issues that the pandemic brought to light. Do you have any final thoughts, Marla, before we move on?
I think I concur with Ron and as well as Vibhu. So on the issue of biologics, so making them more accessible, I mean, with evidence-based, and putting the science out there, because they are still a huge majority of, I wouldn't say majority, but there is still demand for, traditional and complementary based medication, which have not really found their way for COVID-19 management at the moment. So we really do need to emphasize evidence-based practice over here. And also in terms of equitable access, because what our study had shown is that there are still countries where only the special population is offered the vaccine. So either healthcare workers or very, with comorbidities, or they are very ill, or they are very old. So I would quite like to see that everyone has access to these vaccines, and as data has shown that they are beneficial. So that's really my thoughts.
Thank you, Marla. Okay, colleagues, your question for a couple of minutes' time is, what would be the one take-home message for the pharmacists who have been in attendance to take away from this webinar? I'll give you a couple of minutes to think about that, and I'll come back to you in a second. So, colleagues, I wanted to just spend a moment or two with you to reflect. I had some questions at the start of this session. I don't think we need long for this, but if anybody's got any immediate comments, please put them in the chat box so we can capture them. So my questions for FIP and for our member organisations and for our profession would be, what are the generic lessons we can learn from the pandemic? And we've just gone through a few of them just now. What are the core elements of supply chain logistics that we can take from the lessons we've learned during the pandemics to other settings or other areas of work? I think we've just mentioned not only the opportunities for example, biologics, but also all of the issues around hesitancy, truth, evidence, the things we have to do to persuade colleagues and the public to understand the place of vaccines and other medicines. Should we develop some core guidance for this work, or are there some further update events that could provide us all with some tools and guidance? Would that be useful for the audience? Would be a question I have. What can we take from these learnings to help us prepare for future pandemics. And I just wanted to mention here and now that FIP is undertaking some learnings across the different areas of the pandemic. So I just mentioned, Ron just picked me up on 100 weeks, more than 100 weeks. By the time we get to middle of October in 2022, around the 4th anniversary of the Astana Declaration, that will be around 1,000 days we've been living with the pandemic since it was formally announced. And what FIP wants to do, and we're in the middle of doing, is looking at each 100 days, how did we respond? And what did our member organisations or our members do at that time? We've got some responses to that, but there'll be lots of opportunities for us to gather that. And then we will learn what we should do to prepare for the next pandemic, because we really feel that if we just go ahead and prepare for the next one without doing the learnings or seeing what went really well as what the challenges are, we'll lose so much of that rich learning. So keep your eyes peeled for that work. But my big piece of work today is, if we were to itemize all of the learnings from Ron, Vibhu, and from Mala, would there be a set of core guidance that we could create that would support everyone in the pandemics to come? So add your thoughts to the chat box, colleagues, on the event, and then I'll take a moment or two to just walk you through some of the FIP upcoming events that we have in our portfolio for this year. And then I'll come back to our panelists for the final question before we close. So our first one that I wanted to mention to you, face-to-face, is coming back. We're planning to have our first event post-pandemic. The FIP Pharmacy Practice Research Special Interest Group summer meeting will be held in Utrecht on the 4th and 5th of July. This is really open for all PhD students and the supervisors, researchers, academic, professional organisations and practitioners involved in research. We'd love you to join us. The programme will offer interactive workshops, keynote sessions, networking. Remember what networking was, colleagues? And a closing panel discussion. Book your place now, register before 30th of June. And I can speak from experience in my career. Some of the colleagues I met early in my research career, some 20, 30 years ago, are still best friends now. And it's really lovely. The next event, of course, those of you who are with us right at the start of the event heard some amazing Spanish guitar music. We're excited to invite you to the 80th FIP World Congress of Pharmacy and Pharmaceutical Sciences in Seville in Spain from the 18th to the 22nd of September this year. And we are here united in the recovering of healthcare. And I think today's event really shows that we are not out of the woods yet, nor ever should we be, but we're taking the lessons that we've learnt with us. Registration abstract submissions are open. You'll see that we have programme topics under these 3 banners, and we're looking forward to an event slightly different to previous global congresses, but much more networking and time spent together, which I think we all want and need. So I'm going to take you now, colleagues, back to, oh yes, and then we've got all our future digital events, which I know the team have put in the chat box for you. So as we wrap up now, I'm going to go back to that question I asked of my stars on the panel. What would be the one practical take-home message you would offer to pharmacists? And I'm going to start with Vibhu here. Vibhu, Mala, and then Ron.
Right. Thanks, Catherine, and really excellent summary of our discussion. So the answer to that, Catherine, would be I would request all my colleagues across the world to advocate for further pharmacist roles in COVID-19 vaccination and delivery of services in general public health services. So as we saw, pharmacy, how good they're distributed with evidence from research in other disease areas like, pharmacy services, delivery of distribution of safe birthing kit even have reduced have contributed to reducing mortality of, child related to childbirth. So this is something that we can have another good example of how pharmacy involvement can actually make a difference. So in countries where pharmacists have got limited roles, I would encourage all colleagues to make that policy advocacy and get your other professional societies, other professional discipline on board. And this is about giving the best healthcare and preventative care to patients, and not about trying to establish that's not the first intention. Of course, it helps build the trust and expand our roles further, but the patient health support, prevention of pandemics should be the core goal going forward. So if I could request everyone to share some good examples happening elsewhere to advocate the policy in your own country. Thank you.
We can do a lot to help with that, Vibhu, with our case studies and our showcasing from other countries. This is really mobilised. Marla, your single one take-home message to the pharmacists on the event.
Okay, so it's lovely to see everyone here, and I do hope that you do join FIP as members. So what I would like to say is that do practice evidence-based pharmacy wherever you are, whether it's research, whether you're at the community settings, whether you're at hospital-based or you're researchers. So many of our consultations are actually given sort of free of charge, unlike other healthcare professionals. So do try to advocate, knowledge, as well as try and position yourself, more sort of as frontliners, and try to give advice and good updated knowledge to your end users, i.e. the public. And also innovation is key. So whether it's flow to certain procedures that you have, or whether it's to do with vaccination or other relevant current services, try and innovate and try and do something, think out of the box, because that would really make the difference. And if possible, do put your findings out so that the rest of us can benefit from it. So that's it from me.
Thanks, Marla. I think there's some really good points there that you've been an advocate for. Get the facts. You can always ask colleagues for facts and for the evidence, and to innovate, which is what our profession has been doing globally through the pandemic. Ron, I'm not meaning to put too much pressure on you, but the last word is with you. What would be your
Here it is, Catherine, nice and tight.
Message. Lovely.
We all made so much progress at the pharmacy level through the supply chain to get rid of so many of the barriers to keep the flow going. Unfortunately, and if I could say this as USP, our tools work towards that kind of pipeline. But the real challenge is the hesitancy. In the end, small improvements in the logistics aren't going to make that big a difference as much as uptake. And so I don't propose an answer on that, except that needs to be the focus in now and in the future. And Catherine, I look forward to seeing you in Sevilla.
I can't wait, Ron, to see you and all our colleagues again. That's fantastic, colleagues. We've got advocacy, we've got evidence-based, and we've got address the hesitancy as the take-home messages from today. That was such a valuable session. We've got a couple of minutes over, colleagues, but I really can't imagine that anybody regrets that at all. I've loved listening to our panelists today. Thanks so much for your preparation and for attending today. You really are superstars, and we're really delighted that you took the time out to help us with this hugely impactful area of practice. Thanks to everybody who's attended, and thanks to the team who have supported us with the slides, with the logistics, with the chat, and with the Q&A. A great event. I'm super proud to have been the chair. Take care, everybody. See you all soon. Bye for now.